You guys ready for break? I'm forgetting you guys are on break already. So, we are starting the final module in cardiology. So, today starts the arrhythmia. So, even though we have fewer lectures to cover for arrhythmias than we did for on the last exam as an example, most people find this portion to be the most difficult. Just because of the content area. If you ask any practicing pharmacists, they probably know very little about antiarrhythmics. It's just one of those areas that it's like oncology in general. There are people that love it, that know it extraordinarily well. We have a few in this building. Most other people want nothing to do with it in any way. The same goes with arrhythmias. There's a few people that know it really well, and most people want to know nothing about it, essentially. So it is a challenging topic. The way I wanted to introduce it was to go over EKGs and present the different portions of the EKG, why we care, what role the pharmacist has in interpreting EKGs, and then basics of how different rhythms present on the EKG, so that when they're talking about them, when you start talking about the management of the different arrhythmias, you have some sense of what they are, what they look like, things like that. So obviously, cardiologists get paid a lot more money than we do to read these. So you don't have to be an expert. It's more about the basics. Okay? So the goal is, at the very end, we'll be able to look at this EKG and say, okay, what's going on? So this came from a 37-year-old male who complained of palpitations, could feel his heart beating abnormally, was very uncomfortable. And this was the 12-lead EKG that it took. So if you look at that bottom line, anybody have any idea what's happening there? Hopefully, if I can do my job, at the end, we'll have some semblance of, when you look at this, at least tell a few basic things about it, and have some idea of what's happening, the causes. Okay? So that's the goal. So we'll come back to this at the end and see if we have achieved that goal. So, remember, you are the pharmacist. You don't have to worry about everything. It's just the basics. There are times where we do have to recommend that EKGs be gotten. If the measures aren't on there that we need, sometimes we do need to do it. Obviously, most specifically in a hospital, particularly in an ICU setting, but it certainly does happen. Your job won't entail, for the most part, reading them. It's just, again, understanding the basics. So that's what we're going to be covering today. If you do want to know more, I highly recommend this book for Institute. So this is one of the Bibles of reading EKGs by Dubin, Rapid Interpretation of EKGs. A lot of the pictures that are in this lecture came directly from this book. It's a very good, it's not your typical DePiro-esque textbook where it's just millions of tiny, tiny words. It's mostly pictures and relatively few words to present difficult concepts in a straightforward manner, which is why a vast majority of the figures that I'm going to show in the lecture come from this book. If you get into the area, you can know where to go. So when we're talking about the EKG, remember it records the electrical activity of the heart, providing a record of the activity, as well as valuable information about the heart's function and structure. So there's a lot that we can tell just from getting the basic EKG. When Dr. White went over acute coronary syndromes, things like STEMI, one of the first things they do is they get that 12-lead EKG, because it can tell you so much about what's going on with the patient. Quick physiology refresher of how electrical signals are conducted through the heart. Everything starts with the SA node, the sinoatrial node, the SA node. This is what's called the sinus node. It is the heart's dominant pacemaker. It is the commander-in-chief. It is the boss. It tells every other cell electrically in the heart, when it's functioning normally, what to do and when to do. It initiates the wave of depolarization that spreads outward, stimulating the atria, and then eventually stimulating the ventricle. So everything starts in a normally functioning heart electrically with the SA node. So remember when we talked about pharmacology of heart failure, ivabradine, which is the funny channel blocker, works within the SA node. So it works within that pacemaker node to affect conduction. Once the SA node sends out a wave of depolarization, it spreads through the atria in one uniform manner so that the atria can contract and push the blood from the atria to their respective ventricles. That depolarization wave is then picked up by the AV node or the atrioventricular node, and it sends it from the atria to the ventricle. It's then shot down to the left and right sides of the bundle branches, out to the Purkinje fibers equally, simultaneously, to the left and right side of the ventricle. It all depolarizes at once, it all contracts at once, and pushes the blood out. Okay? So when the SA node starts the wave depolarization, it gets through the atria contracts, the wave gets picked up by the AV node and dumped into the ventricles, goes down to the ventricles, and it contracts. Everything relaxes, rinse and repeat. Okay? When we look at a typical EKG, there are certain portions of one cardiac cycle on the EKG that represent each one of these functions. The first is the P wave. The P wave represents atrial depolarization and central atrial contraction. So when you get the little blip of the P wave on an EKG, that means the atria have depolarized and now the atria are contracting, starting to push the blood into the ventricles very diastole. Okay. So it represents the electrical activity of both atria and represents simultaneous contraction of the atria. It's then again picked up by the AV node. Now, if we were to take a cross-section of the heart at the level of the AV node and look at it, this is what you're going to see. You're going to see the tricuspid valve on the right side of the heart. You're going to see the mitral valve on the left side of the heart and the AV node in the middle. In a normally structured heart, the only way electrical signals can be conducted from the atria to the ventricle is through the AV node. The AV node is the gatekeeper between those two structures. There are exceptions to that rule, which we'll get into. However, in most people, the only way the electrical signal goes from the atria to the ventricles is through the AV node. When the AV node picks up that signal, there is a slight pause, which is why there is when you look at the EKG, it goes back to the isoelectric baseline. So you have the P wave showing atrial contraction. When the AV node picks up the depolarization wave, there is a pause slightly before it sends it to the ventricle. And again, that depolarization wave is then simultaneously shot down the bundle branches. The right bundle branch is on the right side of the heart. The left bundle branch is on the left side of the heart. And sends it down to the terminal filaments of the Purkinje fibers out in the myocardium to contract. Ventricular depolarization and then subsequent contraction is shown on EKG with the QRS complex. It's called the QRS because that's the Q, that's the R, and that's the S. And again, that represents ventricular contraction. You then get a plateau phase and then your T wave. The plateau and the T wave represent ventricular repolarization. So after they contracted, after systole, the QRS complex, after it pushes out the blood, both sides of the ventricles, when it's then relaxing, you get the repolarization during diastole, and that's the relaxation of the ventricles where the blood is starting to come back in. Okay. So that is represented by ST segment and then the T wave itself. The ST segment is normally on the same isoelectric line, kind of your baseline resting, and then a broad T wave generally appears. Remember, in acute coronary syndrome, the difference between a stemming and end-stemming is whether that ST segment, which is normally flat in at your isolated baseline, is elevated as a stemming or is depressed as an end-stemming. And so when you're talking about stemming, you're talking about that particular portion that represents the plateau phase of ventricular repolarization. So you have the plateau phase and then the rapid phase. When Dr. White talks to you guys after the break, I guess, the Tuesday after the break, he's going to show you in the initial part of the lecture. That's probably going to be the most dense lecture of the entire semester. You're not going to want to miss that one. Without the problem. It is the most dense lecture of the entire semester. He's going to initially show you all of the ion movements that occur and that cause all of these different depolarizations and segments to contract. Because the arrhythmia genesis has to do with those, and all the antiarrhythmic drugs target the ion movements within the heart that can affect each one of these. So I'm just showing you general structures of the EKG. On the Tuesday when you come back, Dr. White will show you how relative ion movements cause all of these different things and apply all of them. The most commonly quoted segment of a normal cardiac cycle on the EKG as it relates to drug therapy is the QT interval. You've probably heard a lot about that. There's a lot of drugs that can prolong the QT interval. The biggest cause of drug-related arrhythmias are drugs that prolong the QT interval. Since ventricular systole lasts from the beginning of the QRS to the end of the T wave, so contraction and relaxation, the QT interval has clinical significance. So the QT interval represents the entire spectrum of ventricular depolarization and depolarization and repolarization. So if we put it all together on a single cardiac cycle on the EKG, starts again with a P wave. Why they start with P and not with A, I have no idea. That's just what they decided. Starts with a P wave representing atrial depolarization. You have the plateau phase as the AV node holds on to that wave. You have the QRS complex as the depolarization wave is shot down the ventricle, and the ventricle then contract. And then you have the plateau and the rapid phase of the T wave, which both in concert represent ventricular repolarization. Okay, so as you get the full cardiac cycle, you can see how the depolarization wave starts in the atria contract, gets down to the ventricles contract, and then it starts all over again. And they have to do atrial contraction and then ventricular contraction. Okay? Questions on this? There are a number of important segments that are measured and are related back to drug effect and drug adverse effect. They include the P wave and the PR interval. The PR interval covers the span between the beginning of the P wave and the R part of the end of the Q, beginning of the QRS complex. That's the PR interval. So remember, the plateau phase between the P wave and the beginning of the QRS complex is when the AV node is holding on to that contraction. So if the patient is given a negative dromotropic drug or a drug that slows AV nodal conduction, things like beta blockers, things like non-dihydropyridines, things like DIG, that slow AV nodal conduction, it makes the AV node hold on to that depolarization wave longer before it gets into the ventricle. And so you get prolongation of the PR interval. And I'll show you how that can manifest into adverse arrhythmias later on. Again, we talked about the QRS complex, the ST segment, which has to do with diagnosing different types of coronary syndromes, and then the QT interval, which represents ventricular depolarization and repolarization. It is a huge adverse event of not only a number of antiarrhythmic drugs, but a number of non-antiarrhythmic drugs that can affect the QT interval and that can induce arrhythmia. And so within one cardiac cycle, it tells us a lot about the electrophysiologic function of the heart, about the structure of the heart, and there's a couple of them that relate to specific drug therapies and how they may be adversely affecting things, potentially causing side effects. Okay, so one cardiac cycle can tell us an awful lot. When we talk about the 12-lead EKG, this is how it's taken. Notice, if you will, if you count them up, there are only 12 actual leads that are put on an individual patient to get a 12-lead EKG. And that's because a couple of them are calculated. They are broken up into the limb leads, or there is a lead that is hooked up to an EKG machine that goes on the left arm, the right arm. Optimally would go on the inside of the left leg and the inside of the right leg. Clinically, usually it's done at the bottom of the abdomen, and they consider that to be the leg lead, or the limb lead, even though you really put them on the abdomen. And then there are 6 that are put around the heart. V1, which is on the right side of the sternum, V2 on the left side of the sternum, and then V3 through V6 around the side of the heart. Okay, so there are 4 limb leads, and then 6 epicardial leads that are put on. And those 10 actual leads make up the 12-lead EKG. So why do we have to put on so many electrical leads and get 12 different feeds just to find out what's going on in the heart? Why can't we just look at one? The Dubin book uses the analogy of this particular picture of a car. And it says, so why is it necessary to visualize the heart at so many angles? The question is, can you identify what model this car is? Now, there may be some car aficionados in here that can do that. I certainly cannot. Most of us, we need more information. We can't just look at something in one way unless you really know what you're doing. You oftentimes have to look at it at multiple different angles to get all the information you can to really find out what type of car it is. Compared to 65 Thunderbird. The same thing happens in the heart when you're looking at an EKG. It's very difficult to know exactly what's thoroughly going on and to provide an adequate answer to a question. If you're only looking at the heart electrophysiologically from one angle, we need to look at it from every angle, which is why we use 12-lead EKGs. The limb leads, remember we only put on 4, but they provide 6 different views of the heart on the vertical plane. The 6 different leads are AVL, or the left arm, AV right, or the right arm, AVF, feet, and then 1, 2, and 3. 1, AVF are calculated based on these others. So the 4 limb leads provide 6 different angles on the vertical plane through the heart. The chest leads show 6 different angles of the heart on the horizontal plane. Okay, so each one of these, you have a positive inflection, you have a negative inflection from all different angles on the heart. So when you look at the 12-lead EKG, we get 6 different views in the vertical plane and 6 different views in the horizontal plane. So you get 360-degree views electrophysiologically of what's going on in the heart. So that the electrophysiologists, the cardiologists that are trained at that, they can not only look and see what's going on, they can pinpoint exactly where it's going on. When Dr. White did the SETI lecture, did he talk about the different EKG parameters of an anterior infarct, an inferior infarct, posterior infarct, anything like that? A little? Okay. What he was referring to is, on which leads of the EKG are you seeing the ST changes? If you look at a 12-lead EKG, someone that's complaining of your typical heart attack symptoms, where in the EKG ST changes are occurring tells you at what section of the heart the MI is occurring. So it can not only tell you what's going wrong, but where it's going wrong.
Can you just say that again?
Related to the ST?
Yep.
Sure. So when you look at a 12-lead EKG, if someone is presenting with an MI, your typical signs and symptoms, the first thing they do is get a 12-lead EKG. Remember, it has to be read within, I think, 10 minutes of when they hit the door to meet standards. If it's a STEMI or an ST elevation MI, you're going to look at which of those 12 leads you're actually seeing elevation of that ST segment. Elevation meaning above that normal isoelectric line. And there are patterns. You don't have to know now what they are. But if it's in certain leads where you're seeing the ST elevations, that suggests that the MI is occurring in a particular section of the heart, so that the blockage is on one of the arteries that feeds that part of the heart. So if it's on the LAD or the left anterior descending, that's going to affect blood flow to the anterior part of the heart, the left part of the heart, and so the ST elevations are going to occur on the leads that are viewing positively that part of the heart. That's just an example of how you can look at not only what's happening in one cycle, but all of the cycles from all of the different views of the heart and tell not only what's going on, the fact that they're having an MI or a STEMI, but where. And so when they go into the cath lab to visualize the coronaries based on the EKG, they'll know exactly where they need to go. So not only what, but where. And the STEMI is a good example of that. So again, you have your 6 limb leads that look at the heart, the vertical plane, and your 6 chest leads that look at it on the horizontal plane. That makes up your 12-lead EKG. So a lot going on, a lot to look at. So this is an example of what a normal 12-lead EKG looks like. You have your 6 limb leads, your 1, 2, 3, AVR, AVL, AVF, and then your 6 chest leads, V1, 2, 3, 4, 5, 6. So this particular segment here is your 1, that's your 2, that's your 3, and so on and so forth. Okay. So the really experienced folks can look at these and say, what's going on and where? Because we can tell you an awful lot of information about the heart. So the reason I present that to you is that so that you know, at least relatively, what each of these is trying to look. One of the easiest things to tell when looking at an EKG is simple, what the heart rate is. Okay. Obviously, you can take the pulse, but you can also look at the EKG to determine what the heart rate is. Each different structure within the heart has its own native normal rate. The SA node, I said, is the pacemaker node. In a normally functioning heart, anywhere from 60 to 100 beats per minute is what it considers physiologically normal, within the normal range, within the normal capacity of the SA node, if it's healthy. Right? Where things go wrong, and where you're going to start talking about arrhythmias, is when cells go rogue. So I said normally the SA node starts everything, it sends the signal and it tells every other cell in the heart when it should depolarize and go down. When things go wrong are when cells go rogue, and these are what are called ectopic foci. So when cells decide, you know what, SA node has no idea what they're talking about, I'm going to go ahead and do my own thing. And I'm going to depolarize whenever the hell I want. the cells can become potential pacemakers and start to depolarize whenever they want. These are what are called ectopic foci, or cells that are ectopically depolarizing randomly and without order. So and all cells have the inherent ability to do this. So if something is wrong with the SA node, if the commander-in-chief is taken out and no orders are sent, each individual cell has the normal physiologic capability of producing its own depolarization wave. So after a certain period of time, it doesn't get orders. It says, well, I haven't gotten orders in a while. I'm going to go ahead and depolarize because that's what I should be doing. And it can become, these individual cells within the atria can become the pacemakers. Cells within the AV node and within the ventricular tissue can do the same. So again, as I said, normally they wait to get orders to depolarize. If they're not getting those orders, they have the inherent ability to depolarize themselves and be the commander-in-chief and take over. But each type of cell has its own inherent rate. I said the SA node cells, the inherent rate is what we normally see. Your 60 to 100 beats per minute. Most of the atrial cells have a similar inherent rate. Cells within the AV node, if nothing is coming from the SA node or from the atrial cells, the AV node has the ability to be the pacemaker and to drive depolarization, but at an inherently slower rate of around 40 to 60 beats per minute. So enough to sustain life, but not quite as much as the SA node. Similarly, if something goes wrong, and I'll show you some of those later, where the signal from the SA node or from the atrial cells is not getting through the AV node, the ventricular myocytes, if they're not getting any orders, they have the ability to drive depolarization as well, but at a much slower rate, only 20 to 40 beats per minute. So each cell can drive depolarization, can drive the cardiac cycle, but as you go from the top to the bottom part of the heart, essentially, the inherent rate of the cells slows. So if we had to rely on the ventricular cells to drive all of the depolarization of ventricles and essentially drive systole and diastole, it could only do it at a rate of about 20 to 40 beats per minute. Generally, if somebody had a heart rate of 20 beats per minute, they're probably not going to be conscious, and they're probably not going to be alive long. So yes, it can take over in a pinch, but it's generally not enough to sustain life long term moving forward. And that's because of the concept of overdrive suppression. So each one of these different types of cells, even though they have the capability of creating the orders, they know it comes from above. So they know that the SA node drives it. If the SA node fails, the atrial foci, or the atrial cells, assume pacing. If atrial cells fail, the junctional, or the AV cells, can take over pacing. If that fails, the ventricular cells can take over the pacing. So it's the concept of overdrive suppressing. Yes, the ventricular cells can pace on their own, but their own orders are overridden by the AV node, which is overridden by the atria and so on. So it's a fail-safe mechanism. What does this have to do with the rate? How can we look at single line EKG and estimate the rate? We do that by counting lines. So on a normal EKG, there are small boxes, there are big boxes. EKG paper through a normal EKG is fed at a particular constant speed on every single EKG machine in the entire world at the same time. It uses standard, essentially, graph paper. If it's being fed through that machine at the same speed, each one of these little cells would represent a time. So on the graph paper itself, the small boxes or the small lines represent 1 millimeter, and then there are 5 boxes between the thick lines. So if you want to estimate, if you're looking at that PR interval, that QT interval, and you want to say, what is the duration of that QT interval in seconds? What you do is you count how many either small boxes or big boxes they have, and each one of those represents a real time. The small boxes represent 0.04 seconds or 40 milliseconds. So if you count and then the big lines represent 0.2 seconds or 200 milliseconds. So the big lines have 5 boxes. Each one of the 5 boxes represents 40 milliseconds, so 40 times 5 is 200. You will want to look at the PR interval as an example. So you want to measure the distance between the beginning of the P wave and the beginning of the QRS complex, the PR interval. If it spans from one thick line to another, the beginning of the P wave, beginning of the QRS complex, that would represent 200 milliseconds. Okay? So by counting the small boxes or by counting the thick line boxes, you can estimate in milliseconds the duration of those intervals. And that's important because when we talk about what a normal PR interval is, when we talk about a normal QT interval, you're talking about milliseconds. And that can be estimated by counting the boxes between them. We can also do that to estimate the rate. So to estimate the heart rate on the EKG, we're going to count the thick lines. So if you look at an EKG, you find the first R wave, which is the peak on the QRS complex, that lands around one of the thick lines. You're then going to count how many thick lines there are between that R wave and the next R wave. And each one of those thick lines represents a beats per minute. As an example, so we'll find an R wave that falls on one of these black lines, and then we start counting the thick black lines until the next R wave. Okay? And there's a particular sequence to them. 300, 150, 100, 75, 60, 50. What this means is, if the next R wave fell about this first black line, the heart rate would be estimated at 300 beats per minute. If the next R wave fell at about this black line, it would be about 75 beats per minute. Okay? So you can look at one R wave that falls around one of the thick black lines, and then count how many thick black lines there are until the next R wave, and using this sequence, you can estimate what the heart rate is. Okay, so if you look at an example, so this is just a cartoon example. So we find an R wave that's right on around the thick black line, and we're counting how many thick black lines until the next R wave. Okay, so you go 300, 150, 100, 75. Okay, the R wave fell between the 75 and 100, so the heart rate is 85-ish, something like that. So that's how you can estimate what the heart rate is based on looking at an EKG and using this method. Okay? 2 more cartoon examples, and we'll show you some real examples. So again, finding the R wave that falls on one of the thick black lines, use the next R wave, and then you count 300, 150, 100. The R wave in this instance falls on this third thick black line, so that heart rate is estimated at 100. And now a slower one. Again, 300, 150, 100, 75, 60. Oh, okay. The R wave falls on the 60. The heart rate is estimated at about 60. And then you can use a practice tracing here to do that. So we'll do this together. So you look at an EKG. Okay, so this R wave falls on one of the thick black lines. Here's the next R wave. So let's estimate the heart rate, right? So we're going to go 300, 150, 100, 75, 60. The heart rate is estimated at about 60 beats. Does that make sense? Here's a few more examples that you can practice with. I'll do one more with you. Let's go with A. So this R wave is about this thick black line. Here's the next one. 300, 150, 100. It's about 100, slightly less. Okay? And then you can use these others to practice that as well. So it's a nice, quick way to look at a single EKG strip and estimate what the heart rate is. There will be an EKG strip on the final exam where you're going to have to do it. If you don't want to share that with the other 2/3 of the class that aren't here, that's up to you. But it's going to be something that looks like that. And which of the following is the estimated heart rate on this EKG? And you have to use this system in order to determine. Okay? Good. So you can use these to practice. Questions? You want to take a break, or do you want to head on to part 2? A few twos, or give me a peace sign. You want to just motor through? Yeah? All right. So now let's look at rhythms. Okay? So again, a refresher, everything starts with an SA node, normal 60 to 100 beats per minute. How do you, when you look at an EKG, when you look at a single rhythm strip, determine whether it is a normal rhythm? What does normal mean? Normal means 2 different things. It means the relation between the P wave and the QRS complex, and the relation of one QRS to the other. So 2 different things. In a normal EKG, every P wave is followed by a QRS complex, and every QRS complex is preceded by a P wave. The other part of normal is that every cardiac cycle occurs at the same rate, at the same distance between them. So if I was to take out calipers and measure the distance between this one and that cycle, it would be the exact same, essentially, as every other cardiac cycle. So that is what constitutes a normal rhythm. A P wave before every QRS, a QRS following every P wave, and every cardiac cycle, or the distance between the R's, is constant. So that tells you SA node, and at a normal rate. That tells you that SA node is driving things. You're getting consistent atrial depolarization, followed by consistent ventricular polarization, and that ventricular polarization is preceded by normal atrial depolarization. And that everything is occurring at a normal response. And at a normal rate that would be driven by the SA. Okay? So that's what is meant by a normal rhythm, or regular rhythm. Now we go into things that are abnormal. Let's start with the tachyarrhythmias. So when we're talking about tachyarrhythmias, we're talking about fast rates. So tachy means fast. Depending on how fast the rhythm is, can be designated in a couple of different buckets. So as an example, for rates that are between 150 to 150 beats per minute, these are not assigned cutoffs, but ish. That can be a normal tachycardia. A flutter is between 250 and 300 beats per minute, and a fibrillation is between 350 and 450 beats per minute. So depending on where the arrhythmia is originating in the cell, or in the heart rather, it can be firing at these different rates that can be considered flutters, fibrillations, or tachycardia. So we'll start with sinus tachycardia. What does sinus tachycardia mean? This is a normal rhythm that is just fast in its rate. So if you look at this example, every P wave is followed by a QRS. Every QRS is preceded by a P wave. So you have P, QRS, T, P, QRS, T, P, QRS, T. and the distance between the R's is essentially the same. So this tells you the rhythm is originating from the SA node. It's just at a higher than normal rate. So it's a tachycardia because it's higher than normal, it's faster than normal. The sinus means that it is being driven by the sinus node, the sinoatrial node, or the SA node. So a sinus tachycardia is a normal rhythm, just fast, for whatever reason. Okay. But everything is still being driven by the SA node. One of the different types of abnormal rhythms, tachyrhythms, is what's called SVT, or supraventricular tachycardia. So it's a tachycardia, and that is a faster than normal rhythm. But rather than being a sinus tachycardia, it's what's called a supraventricular. Supraventricular meaning it happens above the ventricle. Why do they just can't call it an atrial tachycardia? I don't know. They have to call it a supraventricular tachycardia. What this means is that this is a fast rate that is not being driven by the SA node, is being driven by another atrial cell. How do we tell that on an EKG? Look at it here. So you can tell that the rate is fast. If we were to estimate it, again, look at the R wave here, it falls on the thick black line. 300, 150, whoa, that's probably maybe 175, something like that. So it's a tachycardia. So how can we tell it's supraventricular? So we have no discernible P wave. So we have a QRS and a T, a QRS and a T. So this is an abnormal rhythm. Remember I said that in a normal rhythm, you have a P wave followed by a QRS. Every QRS is preceded by a P wave. In this case, we do not have a P wave. So that tells you you're not getting consistent atrial depolarization starting from an SA node. So it's a supraventricular tachycardia. And this is an abnormal rhythm. So it could be within any of the atrial cells. It could also be what's called a junctional rhythm, or starting from the eating. Make sense? Let's look at one that is occurring within the ventricle. So this is a ventricular tachycardia on this side. So it's a tachycardia because it's a fast rhythm. Even though the morphology is very different, this is the peak of the R. So if we find an R that is around the thick black line, I guess kind of this one, and you go, well, it's tough to tell on this one, isn't it? This is a tough one. 300, 150, again, probably the 175. Right? So it's a tachyarrhythmia, it's a fast rate. But now, it's being driven by a ventricular myocyte. So if you look at the left side of this, it is a normal rhythm. You have a P followed by a QRS. You have a QRS preceded by a P. And everything is at a normal rate and a normal distance. So you can say the early part, this is being driven by the SA node as a normal rhythm. All of a sudden, something bad happened right there. And the ventricular myocyte took over and went haywire. There is no discernible P waves. All you see are very large, very wide QRS complexes. What this tells you is that this is a rhythm that is being driven by a ventricular cell. Any rhythms that are driven by ventricular cells are going to have this very tall, very wide morphology to them, as opposed to a QRS complex where it's being driven by the SA node. So you can easily see the difference between that and one of these. So this tells you it's a ventricular rhythm, it's fast, it's a ventricular tachycardia.
I thought you said that if the nuclear cells could only do 20 to 40 beats.
That's when they are behaving normally.
Okay.
That's when they're behaving normally. This is obviously not behaving normally. That's how we can tell something is wrong. Now, if we saw a ventricular rhythm like this, but at a rate of 40 beats per minute, then we would know still obviously something's wrong because the ventricular cells have to take over, but everything is functioning normally. In this case, we can tell, yes, the ventricular cells have taken over, but it's at such a fast pace, it's irritable for some reason, so something bad is happening. This is a potentially fatal rhythm. Something bad is happening. We need to fix that case. So normally functioning cells in ventricular are only 20 to 40. Well, when they go berserk, they can go berserk. This is an example, just an example of how you can actually have runs of ventricular cells that just periodically pop their head out to say hi. So you have a normal thing going on, and then it goes, and then okay, and then it goes back. And that's essentially what's happening in that heart is something is wrong. Those ventricular cells are pissed for some reason, and they just randomly yell. As opposed to this one where it's just hi. Gotta make this interesting stuff. It would be funny if you put on a stethoscope on someone's heart. They'll be dying, but you'll be laughing. This is what's called a monomorphic ventricular tachycardia. Monomorphic meaning the morphology of every complex is essentially the same, meaning that the peak and valley is about the same size. So monomorphic. The reason I say that is this is an example of what's called a polymorphic ventricular tachycardia. So we can tell it's a tachycardia. Look at the peak of the R, or the next R, look just under 300, right? So take the R, here's the next flight line, just under 300 beats per minute. So it's a tachycardia. You can tell by the wideness of the cycle that it is a ventricular tachycardia. And it is polymorphic because the morphology changes. The peak and valley goes up, goes down, goes up, goes down. This is a type of polymorphic ventricular tachycardia called torsade de poids, twisting of the points. Probably the most common drug-induced arrhythmia. You've probably heard the term torsades before, so drugs that can cause torsades. Drugs that prolong the QT interval can induce torsades. This is what torsades look like. It is a polymorphic ventricular tachycardia, and it looks like a twisted rivet, where the rate is 250 to 350 beats per minute. And this can be fatal. So I present that so that when you start hearing the term torsades more, you'll know torsades is a polymorphic ventricular tachycardia. So those were atrial and then ventricular tachycardias or tachyarrhythmia. Now we'll move on to the flutters. So, flutter, let's start with atrial flutter. A flutter originates with an atrial automaticity focus, meaning an atrial cell that is starting to drive things all on its own. So every once in a while you'll have a cell that is, the SA node is still functioning normally, but now we have one particular cell that is now starting to drive things on its own as well and cause rapid depolarizations of the atria. You know there are rapid depolarizations of the atria because we have multiple P waves and then the AB node, when it's good and ready, will send that down to the ventricles. And then we have multiple atrial depolarizations, and then the ventricle will send it down. This is what's called atrial flutter. So the atria itself is fluttering, and then the ventricle is sending it down. Right? You know that it's fluttered because it has a type of sawtooth pattern to the P waves. So that is atrial flutter. So it's an abnormal rhythm in that every P wave is not followed by a QRS, but every QRS is preceded by a P wave. And the distance between them is about the same. So it is still an abnormal rhythm. Okay. You can also, although it's much more rare, a little bit harder to classify, you can also have ventricular flutter. Now notice that ventricular flutter looks an awful lot like ventricular tachycardia. The only difference in designation is the rate. Ventricular tachycardia was at an abnormal rate of about 150 to 250 beats per minute. Ventricular flutter is about 250 to 350 beats. So think about whatever your resting heart rate is right now for those that are drinking them up. Think about what it would be if it was 4 to 5 times faster than what it ever is. That would be ventricular flutter. Right? That's that. And then the fastest of the tachy rates is the fibrillation. The most common type of fibrillation that Dr. White's going to be spending a lot of time talking about is atrial, and is the most common arrhythmia, is atrial fibrillation. So what does atrial fibrillation mean? Unlike atrial tachycardia or supraventricular tachycardia, unlike a flutter, atrial fibrillation is caused by multiple ectopic foci rapidly discharging. So unlike with a normal rhythm, where the SA node drives everything, or supraventricular tachycardia, where you may have one particular cell take over, in atrial flutter, you have multiple cells that are going haywire. So you have multiple ectopic foci that have decided to take over. Ventricular fibrillation is the same thing, where you have multiple foci within the ventricles that are taking over in a completely erratic nature. If you could estimate the rate, it would be in the 350 to 450 beats per minute. Okay. So let's go back to atrial fibrillation. The way I like to describe atrial fibrillation as opposed to normal atrial contraction is think of a completely flat pool. So if you're going to go swimming in a pool where there's no wind and the filter's not running, the water is completely flat, right? If I was to drop one raindrop in the top corner to represent the SA node, just like one drop in a pool, what would you get in the pool? You would get one wave in the pool that goes uniformly across the entire pool and touches all parts of the pool the same, in one uniform manner. That's what happens in a normally functioning atria. When you have SA node fire, you have one depolarization wave that goes through. AFib, let's take that same flat pool and just make it rain. So we're having multiple cells that are firing randomly everywhere. And so those depolarization waves, just like the waves in a pool, are bumping up against each other on completely random patterns. And so you lack uniform atrial depolarization because you have multiple waves going on all over the place. And you can see that on an EKG. There are no discernible P waves on EKG of someone that's in active atrial fibrillation. So this is an abnormal rhythm. Atrial fibrillation is often called abnormally abnormal. So what does that mean? Remember the two things that I said denoted a normal rhythm. P wave before every QRS, QRS after every P wave, and the RR interval consistent. Right? Those are the two main things that denote normal rhythm. AFib is an abnormally abnormal rhythm, meaning there are no discernible P waves, so there is no P before QRS, there is no QRS after P, because there is no P, because you're not getting consistent atrial depolarization and contraction. And the distance between every R's or every QRS complex is not consistent. So it differs. Why does it differ? Well, that's because the depolarization waves are going everywhere. The AV node is being hit from all sides at all different times. And then every once in a while, randomly, it gets hit with the depolarization wave when it can shoot it down, and it shoots it down. And then it's being hit by all kinds of waves, and then, okay, fine. And then they hit by, okay, fine. So because the AV node is not being presented depolarization waves consistently, it can't transmit it to the ventricles consistently. So that's why it's considered abnormally abnormal. Okay. If you could measure the atrial rate, it would be in that 350 to 400 beats per minute. It's essentially just sitting there equilibrium. Okay. So this is an example of how it could look. No discernible P waves, so it's abnormal. And the distance between every QRS is not consistent. It's abnormally abnormal. So that's atrial fibrillation. The same thing can happen in the ventricles. You have ventricular fibrillation, where you have multiple cells that are going haywire, and it looks completely random. Easy. It goes completely random on the EKG. There's absolutely nothing discernible of anything anywhere on that. It looks like a 2-year-old coloring with a crayon. There's nothing discernible anywhere. There's no discernible P waves, forget it. There's no discernible pattern to the QRS complexes. The ventricle is just kind of sitting there like a bowl of jelly, just kind of shaking around. That is VFib, or ventricular fibrillation. That is big. Very good. This is a rhythm where, on the medical shows, they put up a pageant. Pretty much the only way you come out of that. Right, so that's that. So that's ventricular fibrillation. Okay. So you can see how it's deteriorating from a ventricular flutter. Very fast, soft tooth pattern, completely random morphology. Kind of looks like a detached, but it's a little bit faster and more random. Can deteriorate into a VFib where it's completely random. So a patient can start off in one, and then it can deteriorate, and then eventually it would go flat. So these are some examples of how VFib can look. Completely random, completely lacking anything discernible. And this is where we're getting close to asystole or flatliner. Yeah. Cardiac death. And then this would happen. So this is what we're talking about when we're talking about any one of these. S is the code. This is the event. So, questions on the tachyarrhythmias? Okay. Now let's flip the coin and talk about the bradyarrhythmia. So these are the slow guys. Okay? So we can start just like we started with sinus tachycardia. We'll start with sinus bradycardia. Meaning it's a sinus rhythm. Everything starts within an SA node. It is a normal rhythm in that there's a P wave before every QRS. QRS following every P wave, and the distance is the same. It's just slower than normal. So it is a sinus, or they say no, bradycardia. Okay. When we talk about bradyarrhythmias, we're not going to talk about blocks. Blocks meaning one of the structures is holding on to that depolarization wave so long that it blocks the development of ventricular depolarization in a QRS complex. So this is an example, although we don't see too often, of a sinus block. So it is a sinus rhythm. P wave is followed by a QRS. QRS preceded by a P wave. So it is a normal rhythm. Everything is equidistant. It's just this one. So that's an example of a sinus block. For whatever reason, it just, and then everything went back. There are some conditions where this can occur on a somewhat regular basis. An example of this is what's called sick sinus syndrome. This is a syndrome where the sinus node is sick. The reason I present this is sick sinus syndrome is one of the contraindications to things like beta blockers. I'm sure Dr. White probably at one point in the class presented you with contraindications to beta blockers. Sick sinus syndrome was one of them, which is why I want to show you. This is what it is. So it is still a sinus rhythm in that every P wave that you see is followed by a QRS. Every QRS that you see is preceded by a P. And when you do get multiples, they are regularly spaced. However, we get a lot of random drops. So it is still a sinus rhythm, but it is a syndrome where the sinus is sick. Sick sinus. If we were to give a negative dromotropic drug, something that is going to slow rhythms even more, slow conduction even more, it could make this even worse. Which is why sick sinus syndrome is the contraindication to be acquired. Okay? Don't worry about Brady Tacky, that's getting way too complex. I probably should have blocked that out. No pun intended. Just to present, I wanted to present the sick sinus syndrome just because you see it always on the list of contraindications, but most people have absolutely no idea what it is. Nice. Now we're talking about atrioventricular blocks. And the reason we're going to talk about these blocks is they are very often drug-induced. Just like prolongation of the QT interval and potentially development of torsades can be drug-induced, blocks can be drug-induced. There are three types of blocks that increase in severity. They are called first degree, second degree, third degree. Increasing in severity from first to second to third. Think of it as a burn. Second degree burn is worse than the first, third is worse than the second. I'm going to present this, and then I'm going to give you what I think, and I found this over the spring, is a fantastic analogy to remember what's going on with each one of these. Because this is not easy for most people to remember, the difference between these blocks. Okay? So I'm going to present it, how it is, and then give you what I think is a phenomenal analogy to try and remember what's going on. So we'll start with first degree AV block. First degree AV block is prolongation of the PR interval beyond 200 to 220 milliseconds, something like that. What this means is that the AV node is just holding on to that depolarization wave a little bit longer than normal before it transmits it down. So it's just a little bit longer of a pause. So if you look on the EKG to measure the PR interval, you can count how many small blocks. Remember, each one is 0.04 seconds to 40 milliseconds. 5 of them. Each thick line is 200 milliseconds or 0.2 seconds. So the distance between the beginning of the P, the beginning of the QRS complex, or the PR interval can be measured. A normal PR interval is up to about 200 to 220 milliseconds. First degree AV block is when it exceeds that. So drugs that can slow AV nodal conduction can induce a first degree AV block.
Would this be on every cardiac cycle or just a couple like before?
It would be on every. Good question. If we give somebody let's say we start them on metoprolol, and they're started on DIG, and for some reason they start them on diltiazem. So now we have 3 different drugs that can all slow AV nodal conduction, negative dromotropic drugs. You can induce first-degree AV block. All first-degree AV block is making that AV node hold on to that depolarization wave a little bit longer than it should and go beyond that 220 to 240 millisecond threshold. Patients are normally not going to be symptomatic. It's just an EKG finding, but it can be predictive of worsening. So first-degree AV block is just prolongation of the PR interval. But you're not actually missing any beats. They're just delayed a bit. And it would be consistent from one cycle to another. Drug therapy-wise, that could just mean let's back off on the dose a little bit. Because this can be a predictor of bad things. So that's first-degree AV block. Okay? So if you look at on an EKG here, you could count or estimate what the PR interval is. So the beginning of the P wave falls on this big black line. You can count how many thin, small cell blocks, how many big blocks between the beginning of the P and the beginning of the QRS. So there's small blocks, let's see, 1, 2, 3, 4, 5, 6, 7 times 40, 280 milliseconds-ish is what this PR interval would be. That is beyond normal. This is considered first-degree AV block. Okay? Now we're going to move on to types of block where you're actually starting to miss beats. This is second-degree AV block. So second-degree AV block allows some atrial depolarization waves to conduct into the ventricle, while some are blocked, leaving lone P waves without an associated QRS. This is where it gets a little bit more complex. There are 2 types of second-degree heart block. Oh, this is challenging. The first type of second-degree heart block is what's called Winky block. And that was that fun. If you want to close that put it in here, no, if you want to chuckle, I used to put it on here in the lecture. I'm not sure why I took it out. Some med students made a video that's on YouTube about Winky Bach that is set to Timberlake's Bringing Sexy Back. Something about diagnosis Winky Bach, yeah, and then they sing the whole song about type 1 second-degree heart block, or Winky Bach. It's actually pretty funny. It helps you remember what Winky Bach is, and that it's a type of second-degree heart block. What Winky Bach is characterized as is progressive lengthening of the PR interval before a QRS is dropped. So this goes back to your question earlier. With first-degree heart block, the PR prolongation is consistent and you don't miss any beats. With second-degree AV block, Winky Bach, you get the PR interval gets progressively longer. So the AV node is holding on to that depolarization wave a little bit longer, too long, missed a QRS. And then the cycle starts again. So now with second-degree heart block, now we're missing beats. And it's characterized by progressively lengthening PR intervals before you miss that QRS, and then it repeats. So this is the Winky Bach type of second-degree heart block. The Mobitz type of second-degree heart block is where you have consistent lengths of the PR interval, but you are just randomly missing QRS. It is in a normal pattern, a consistent pattern, not random. So in a 2-to-1 Mobitz AV block, for every 2 P waves, you get a QRS. And then 2 P waves and a QRS. 2 P waves and a QRS. And then you can have a 3-to-1, where you have 3 P waves, QRS. 3 P waves, QRS. Okay. So Winky box, second degree heart block, progressive lengthening of the PR interval before a drop, and then in recycle. Mobitz type heart block, consistent PR lengthening, but every so many P waves you get a drop. The Winky block is particularly important because this is the type of secondary heart block that is drug induced. So you can have patients that may start off as first degree heart block, prolongation of the PR interval, and if it is left unchecked, can deteriorate into second degree heart block, a Winky block type. The Mobitz type of second degree heart block is not drug induced, it's caused by other things. The first picture I showed you is within the AV node itself. The Winky block originates from the AV node itself, which is where the drugs work. The Mobitz can occur anywhere from just after the AV node to the beginning of the His-Purkinje system and the bundles. Drugs don't work here. So that's why the Winky block is the type of second degree that is drug induced, and then the Mobitz type is caused by something else. Okay? Again, now moving on to the most severe type of heart block is third degree. Third degree heart block is complete AV, atrioventricular dissociation. Meaning, for whatever reason, remember that the AV node is the only way signals can get from the atria to the ventricle. If the AV node is completely shut off, those signals cannot get through. So you're going to have the atria, you're going to have the SA node firing normally, you're going to have the atria depolarizing normally, but none of that is getting to the ventricle. And so, because of the overdrive suppression principle, the ventricular cells are now going to take over and pace completely on their own and depolarize completely on their own. So if you look at an EKG, you have discernible P waves occurring at regular intervals. Because the SA node is firing, the atria are depolarizing regularly, but there's absolutely no relation between that and the ventricle. The ventricles are depolarizing just fine at regular rhythms. Notice how damn slow it is. This is how you can tell. This is what it looks like when the ventricles are functioning normally. Yes, they can produce beats, but they're pretty darn slow. And there's absolutely no association between the P waves and each QRS. Complete dissociation. So physiologically, from a cardiac output standpoint, the heart rate would only be 20 to 40 beats per minute. Generally not enough to sustain consciousness, for sure. So this is something that has to be fixed. Type 2, like first degree heart block, patients are going to have absolutely no idea. They're not going to feel any different. Heart rate may not even differ all that much. It's just an EKG finding. And then two different types of second degree heart block. You're missing beats. Patients can be sensitive to that. They can feel maybe the palpitations. They can feel when they miss a beat. They can feel that something is abnormal. With third degree heart block, the rate is so slow, they're likely going to lose consciousness. Because it's just not enough outflow of blood to maintain perfusion, and usually that results in loss of consciousness. And so we've got to do something about this. It's a lot to try and understand, and I came across a picture that somebody posted on Twitter once about a good analogy for differentiating between all of these things. And so I wanted to make sure to present it here. So heart blocks are like relationships. In normal sinus rhythm, the P and the QRS are dating and never leave each other's side. So in normal rhythm, they never leave each other's side. A P is always next to QRS, and QRS is always next to the P. Things are hunky-dory in normal sinus rhythm land. First degree AV block, the P and QRS had a fight, and they're keeping their distance. And Maybe they're sleeping in separate rooms. They're still close to each other. Every P is followed by QRS, every QRS preceded by a P. They're just keeping their distance in touch. Right? Type 1, or Winky box second degree AV block, the P and the QRS are in a vicious cycle where they break up and then get back together again. And once they get back together, they start fighting again, they start keeping more and more distance, and then they break up. And then they apologize and get back together again, and then they get into that vicious cycle. Okay? So that's Winky box. Progressive prolongation of the PR interval, and then they break up and the QRS is dropped. And then they get back together and start the cycle. Right? Love this analogy. It makes so much sense. Type 2, or Mobitz, the P and the QRS decide to work it out, but the P is still upset. The QRS goes out and married to a week, just randomly fools around. So, most nights, they're next to each other just fine. But every couple of nights, the QRS goes around and goes out and fools around and leaves the P on its own. Okay. So that's the Mobitz type, second degree heart block. Progress now to third degree. QRS catches the P cheating and completely moves out, and they live their lives completely on their own and no relation to each other. So each is living their life normally, but absolutely no relation to each other. Okay? I think this is a phenomenal analogy. Most of us can really identify with any one of these, if not more than one. And it makes perfect sense of physiologically what's happening. Okay? So when you're trying to remember what a Winky Bach second degree heart block is, if you think of this analogy, it should make sense, and then you can pick it out in a lineup. Okay? The last couple things I have on here are just random representations of abnormalities on EKG, just so that you can visualize it. So, Dr. Wheeler, did she present potassium disorders to you guys yet? Yeah. What?
Our exams after that.
Like today?
Yeah.
Oh, sweet. C and big K drop is one of the most important things. I don't know what she put on that exam. I have absolutely no idea. I didn't know you had an exam today. That shit's important. Relates to treatments of hyperkalemia. So, she's not going to show you an EKG and say, what's the electrolyte abnormality? Very unlikely to happen. Did she show you an EKG when she went over hyperkalemia? Okay, I didn't think she did. That's why I wanted to. So, one of the EKG manifestations of hyperkalemia is peaked T waves. So, when the potassium gets above a certain level, and there's no number threshold, but the higher it goes, the more likely they are to have EKG changes that could potentially result in arrhythmias. But one of those EKG changes of hyperkalemia are peaked T waves. So remember, normally a T wave is kind of rounded, looks like a little hump. You can tell if you have EKG change from hyperkalemia in that it is peaked rather than flat. So you get a wide flat P, you can get a widening of the QRS. This is when the potassium is like 10, which we would never see that can be failed. But if the potassium is maybe 6, 6.5, 7 maybe, you can get peak T waves. This is important because this is where, I'll give you a little exam refresher. That explains why nobody's here, I get it. I get it now, it makes sense. If you are faced with a potassium of 6 and you see peaked T waves, it's going to change the treatment. The first thing you do is you give calcium to protect the myocardium before you worry about giving drugs to lower the potassium. She probably went over that. If there are cardiac EKG manifestations, peaked T waves, you give calcium first. Calcium will stabilize the myocardium to prevent arrhythmias from happening, and then you can give whatever you want to give to lower the potassium. Conversely, hypokalemia, which we don't see EKG abnormalities with as much, not really related as much as it is in terms of the treatment manifestations of hyper. But in hypo, you can get conversely a flattening of the T wave, and you can get a brand new wave called a U wave. So you can get an extra bump. So unlike with a peaked T wave in hyperkalemia, you can generally get a flattening of the T wave in hypo. EKG changes related to hypokalemia are honestly clinically not as discussed as hyper, but she probably listed them, and that's great. So, now, let's go back to this. Okay, so just look at the bottom line. So here you have your 12 leads, and on a 12-lead EKG, they usually often have a composite as well. So you have your 12, and then you have a composite. So just look at the composite at the bottom. What do you think's going on here? So is it a normal rhythm? No. Why? There's a big gap, right? So is every P wave followed by QRS? No. P, QRS, P, QRS, P, QRS, P. Oh. P, QRS, P, QRS. No. We have a block. What type of block is this representing?
I don't know. Type.
Look at the PR intervals.
Mobits.
What's that?
Mobits.
Look at the P. So you have P, you have QRS. You have P, you have QRS. Look at the distance between the P and QRS. A little bit longer. A little bit longer, drop. Short. A little bit longer, a little bit longer, drop. Short. A little bit longer, a little bit longer. This is a Winky Bach second degree heart block. And that's how you can tell the difference between them, between that and Mobits. Now, obviously the cartoon that I showed you, it's a lot clearer. This is what it could manifest more clinically. It's more subtle, but once you can see it, oh, okay, that makes sense. Look at the PR interval. Is it consistent? No. You would have to blow it up a little bit more and actually count, but you can see it's getting progressively longer. So they keep their distance, they're fighting, they break up and get back together. Their distance, fighting. So, second degree Winky Bach heart block is why this young patient is feeling palpitation. Okay. So that's how you can, if you estimated the heart rate on this, you take an R, that's around one of the thick black lines. You can see on a real EKG, it's a hell of a lot easier to see. Run thick black lines, 300, 150, 100, 75, somewhere between 75 and 100, 85, something like that. So you can estimate the heart rate, and hopefully you can identify the rhythm. Questions? Or I let you go, you can go the fan. Remember what's your big key drop. Did she modify that little three drugs around? Did she present those to the tear any of those new drugs? Okay. They're not approved. There are, okay, I don't want to confuse you at all. No. There are 2 new drugs on the horizon that are being reviewed and will likely be coming out by the time you get into rotation, maybe in practice, that are specifically to treat hyperkalemia related to cardiac drugs. So the CVD drop will be expanded.